Look at this slide. Bad bugs, no drugs, superbugs. That means the bugs have become bad. They are not allowing us to conquer them using these antibiotics. So much so, there are no drugs to work against them, and there is drug resistance. With the result, they are becoming superbugs, ordinary organisms. Because of this situation, they are becoming superbugs. Bad bugs, no drugs, superbugs. The Infectious Diseases Society of America, IDSA, has in one of its editorials has focused on this. An antibiotic discovery stagnates, a public health crisis brews. This is the title of one of the articles there. What are the superbugs? Is it only one type of bacteria? No. There are many superbugs that are emerging. The commonest ones are listed here. When do we call an organism to be a superbug? When it is resistant to 2 or more wide-spectrum antibiotics. 2 or more wide-spectrum antibiotics. If it is resistant, we can call it as a superbug. Acinetobacter, Bowmani, Pseudomonas aeruginosa, extended spectrum, beta-lactamase producing Entero-bacteriaceae, Klebsiella pneumoniae, Carbapenemase producing Klebsiella pneumoniae, it's also called KPC, methicillin resistant Staphylococcus aureus, commonly known as MRSA, vancomycin resistant Enterococcus called VRE, vancomycin resistant Staphylococcus aureus VRSA, and of course the new bug NDM-1, which is Escherichia coli. What is NDM-1? We will see the subsequent slides. So this is to tell us that there are not, superbug is not one organism or one type of organism. Any type of organism, if it acquires resistance to more than 2 wide-spectrum antibiotics, can become a superbug. The commonest antibiotics are Acinetobacter baumannii, Pseudomonas aeruginosa, ESBL producing Entero-bacteriaceae, Klebsiella pneumoniae with Carbapenemase production, also called KPC, methicillin resistant Staphylococcus aureus MRSA, and vancomycin resistant Enterococcus called VRE or vancomycin resistant Staphylococcus aureus VRSA, and of course the new NDM-1 Superbug. We will be more concerned in this talk on the NDM-1 hereafter. So the picture here shows 3 different organisms. The ones which are the chain-like ones on the upper left-hand corner are the Streptococcus pneumonia ones, and the cluster-like ones that are seen on the right-hand side, the black background, the tennis ball-like things which are clustered one another, are the MRSA or Staphylococcus aureus, methicillin-resistant Staphylococcus aureus, and the red rod-like thing on the green background on the lower left-hand corner are the extended spectrum beta-lactamase producing Escherichia coli. All 3 are some of the superbugs. Now you see here again the left-hand side, you have got a very beautifully decorated rosette-like appearance, clusters of MRSA methicillin-resistant Staphylococcus aureus. On the right-hand side, we have got the new bug, the so-called superbug of this particular year, the NDM-1, which is the Escherichia coli. We will see what is this NDM-1. They look very attractive, right? They also decorate themselves when they become resistant, so the attraction looks much better. Look here, there is an article, National Statistics of the UK on 22nd February 2007 from United Kingdom. Deaths involving MRSA and Clostridium difficile continue to raise health statistics quarterly spring 2007. Needless to say, MRSA is the superbug till date. MRSAs and KPC, that is Klebsiella pneumoniae, Klebsiella pneumoniae C. These are the 2 important superbugs that we are now dealing. Now the new one has come, the NDM. So look here, the relative mortality due to different diseases bacterial diseases and viral illnesses we see here. Salmonella deaths, tuberculosis deaths, influenza deaths, viral hepatitis, HIV. Compared to any one of them, the MRSA, methicillin-resistant staphylococcus deaths are so many. The red bar there indicates that it is such a highly important agent as far as mortality is concerned. So look at the worldwide prevalence of methicillin-resistant Staphylococcus aureus. So no data is all white color. The red data is 25 to 50% and 5 to 10% is the yellow color. The orange yellow color is 10 to 25%. That's where India is. And we Indians, we have MRSA around 10 to 25% of the MRSA isolates are drug resistant. They are methicillin resistant staphylococcus. Whereas in all those red zones there, what we see in the North America, in Australia, and in the South America, the 25 to 50% of the isolates of the Staphylococcus aureus or MRSA. So whereas you see the very violet ones are more than 50% of the isolates are MRSA in certain regions that we can see on the map. Now, this is the article which has produced all the hype, all the controversy. Appeared in Lancet Infect Dis Journal 2010, issue number 10, and page number 597 to 602, published online on August 11th itself, and it is available in print in September of last year. So the article is titled like this: Emergence of a new antibiotic resistance mechanism in India, Pakistan and UK, a molecular, biological and epidemiological study. Karthikeyan Kumaraswamy is the first author. There are several authors associated with that. Karthikeyan Kumaraswamy works as a MPhil student in the University of Madras in the Department of Microbiology. And the summary is gram-negative Entero-bacteriaceae with resistant to carbapenemase conferred by New-Delhi metallo-B-lactamase or NDM-1 are potentially a major global health problem. These people have investigated the prevalence of NDM in multi-drug resistant Entero-bacteriaceae in India, Pakistan and UK. What is this NDM-1 Superbug? The NDM stands for New-Delhi metallo-beta-lactamase 1. New-Delhi metallo-beta-lactamase 1. So beta-lactamase are many types of beta-lactamase are there, on which metallo-beta-lactamase are a class of beta-lactamase enzymes produced by genetic alteration of the bacterium, and then this is named after New-Delhi. Unfortunately or fortunately, whatever it is, we'll see that it is a gram-negative Entero-bacteriaceae family. The important aspect is it is resistant to carbapenemase and other antibiotics. Carbapenemase are the weapons we have in hand to treat majority of the drug-resistant bacteria. But this particular bug is resistant to carbapenemase, conferred by an enzyme, New-Delhi metallo-B-lactamase. Metallo-beta-lactamase 1 identified and are called as NDM-1. Potentially a major global health problem, because if this becomes virulent and prevalent all over the globe, we don't have an antibiotic to handle this. The prevalence of NDM-1 was investigated in India, Pakistan and UK. It's a multi-drug resistant Escherichia coli producing NDM-1 beta-lactamase. In India, Chennai and Haryana are the two places where this bug has been investigated. Carbapenemase resistant gene is the BLA-NDM-1 gene identified by PCR, confirmed by PCR. The sensitivity test will tell us if the Escherichia coli that we grow is resistant to carbapenemase. Majority of them would be NDM-1. How to confirm that? They have to do a PCR test to identify the genetic background of the NDM-1 as BLA-NDM-1 gene. If that is picked up by the PCR, then it is confirmed. So what they did was they have taken 44 isolates with NDM-1 from Chennai, 26 from Haryana and 37 from UK, and 73 in other sites in India and Pakistan. NDM-1 was mostly found among the Escherichia coli, 30 56, and then Klebsiella pneumonia 111, which were highly resistant to all antibiotics except to tigecycline and colistin. These are the two antibiotics. Colistin is an old antibiotic. Not many people use it. A lot of problems in using the colistin. Tigecycline is another new antibiotic. Except to these two drugs, this bug is resistant to almost every known antibiotic, including Carbapenemase. Most isolates carried the NDM-1 gene not on the genetic makeup on the chromosomes but on the plasmids. So this is a horizontally transferable genetic information on the bacteria. Those from UK and Chennai were readily transferable, whereas those from Haryana were not conjugated. Many of the UK NDM-1 positive patients had traveled to India for one reason or another, or they have traveled to Pakistan within the past 1 year. Now, the potential of NDM-1 to be a worldwide public health problem is so great, and so much so we require a coordinated international effort to combat the menace from this NDM-1 superbug. Look at the Carbapenemase producing Entero-bacteriaceae, the NDM-1. So the BLA NDM-1 is in the gray and the other Carbapenamases are in the red. So in 2003 we don't have any BLA NDM-1 producing bacteria. Likewise in 2004 until 2007. Whereas in 2008 around 15% to 20% of the isolates are showing the gene BLA NDM-1. Whereas when you see in 2009 around 40 to 50% of the isolates have this particular BLA NDM-1. So among those which are producing Carbapenemase or beta-lactamase producing Escherichia coli, when we look at the PCR results, around 40 to 50% of them are due to this particular bug, BLA NDM-1 gene. So look at the distribution here, both in India and Pakistan and Bangladesh, and of course in the UK also. It's not confined to one city or one region of the country. The south, west, east, north, Pakistan, the northern part, the southern part, in England also, all over, east, west, so north, south, everywhere the isolates are there. So the distribution is sort of ubiquitous. NDM-1 resistance parameters, if you look at carefully, it's a very sort of small letters here. If you can see those things, the proportions susceptible for different antibiotics are listed on the left hand side. Imipenem, meropenem, penicillin, tazobactam combination, cefotaxime, ceftriaxone, cefpirone, echetrinone, ciprofloxacin, gentamicin, tobramycin, amikacin, minocycline, tegacycline and colistin. These are the drugs listed. If you see proportions susceptible are 0%, 3%, 0%, 0%, 0%, 11%, 8%, 3%, 0%, 0%. Whereas for tigecycline and colistin, 64 and 89% of the isolates are susceptible. This is in UK. In Chennai also, similar pattern, 56% to 94, in Haryana it is 67% and 100%. In all the three regions you can see that these organisms, NDM-1, whether they are in UK or in Chennai or in Pakistan, they are resistant to almost every known antibiotic except the two antibiotics which we have already talked about, the tigecycline and the colistin. For all others, towards all others, these NDM-1 producing ones are resistant. Now you see the minimum inhibitory concentration 90% of the organisms to be inhibited, that's called MIC90 for NDM-1. For ampicillin it is around 512 milligrams per liter, and then like that similarly thing. One thing is for tigecycline colistin only, it is very low. The grey bars are in Chennai, India, the violet ones are Haryana, the white ones are UK. Uniformly, in all the three regions, the minimum inhibitory concentration for all the other antibiotics is so very high that we cannot use these antibiotics at those doses. Whereas for tigecycline and colistin alone, the minimum inhibitory concentration is comparatively very low, and they are susceptible to that. So how to overcome the superbugs and their resistance. Antibiotic resistance in the hospital or in the community setting is increasing at an alarming rate, and the following steps are essential to counter the menace. What are these steps like? Number one, selecting the most appropriate antibiotic whenever we treat a patient of bacterial infection based on the patient's profile, the risk factors, the suspected infection, the resistance patterns, and the epidemiological background. Administering the antibiotic at the right dose and for the right duration. Changing the antibiotic dosage and therapy based on the information of resistance after the culture and sensitivity results are available. Recognizing that prior antimicrobial administration is a risk factor for the presence of resistant pathogens. If the patient is already treated with antibiotics, it is possible that he is harboring resistant pathogens. Right? Then we have got knowing one's area of antimicrobial resistance profile. One must be aware of, in this particular region, let's say in China, this particular organism is susceptible to these antibiotics. But the same thing may not hold good when you go to UK or USA. So if one knows the epidemiological and bacteriological background of the antibiotic resistance profile, appropriate antibiotics can be chosen. Safe practices, needless to say, hand washing plays a very important role in reducing the nosocomial infections and in the transmission of infection. It is estimated that we will be touching our face with our hands at least 500 times a day. Imagine this number of 500 times touching the face. If our hands are not clean, we can transmit these organisms to our respiratory passages and into our mouth, into our conjunctiva, into our skin on the face. It's imperative that appropriate hand washing. Hand washing means not just putting little soap and putting your hand on that. It requires a minimum 20-second contact with soap lather, rubbing both sides of the hand, both the palmar aspect as well as the dorsal aspect between the fingers, and thoroughly cleaning the nail beds and fingertips, also rubbing the tips as though you are doing a surgery, going to go for an operating theatre. Such sort of precautions are essential. How many of us are really doing this when we test the patients? The other alternative is that people think that we may have gloves, but gloves are no alternative to hand washing. Before putting the glove and after removing the glove, again you have to wash. So the important aspect is hand hygiene, and then etiquette, that is cough etiquette and hand hygiene, very essential. And then washing hands before and after suctioning, touching the ventilator equipment, and or coming in contact with the respiratory secretions, or nursing the patient, or attending to the patient. The attendants as well as the health staff use a continuous subglottic suction endotracheal tube, or intubation is expected to be more than 24 hours, so that constant suction of the secretions is done. If possible, if medically not contraindicated, keep the head end of the bed elevated at least to 30 degrees, so much so there is no cooling of the secretions in the pharynx, in the dependent area. These are some of the safe practices. Cough etiquette, hand washing, and then hygienic measures inside the hospital and at home are essential safe practices to prevent the transmission of drug-resistant bacteria from one person to another and one patient to another. Are we having any newer antibiotics in the pipeline? So much of drug resistance, so many drug resistant bacteria, MRSA, KPC, VRE, VRSA, NDM, name any different types of bugs are coming. Do we have anything to offer? There are certain new drugs that are coming, but it will take a long time for them to be available clinically for clinical use. Dalbavancin, oritavancin, telavancin are one group of drugs. Girinoxazine is a fluoroquinolone. This is a new generation fluoroquinolone. Ceftobiprole is a new generation cephalosporin. Daptomycin, available as cubicin, and ceftaroline is another new generation cephalosporin. Ferropenum is a carbapenem, newer carbapenem after the imipenem and other things, ferropenum. These are newer antibiotics that are available for use in the future. Now, the question is it a dead end? Are we defeated? We have been conquering the battle of war against the bacteria, battle after battle and war after war against different types of bacteria, starting with your Treponema pallidum in the very early days, producing tertiary syphilis, secondary syphilis, and lots of devastating consequences. Then, of course, the tuberculosis, leprosy, and your diarrheal diseases. Many of these bacterial infections, salmonella, needless to say, any number of bacterial infections have been conquered with the use of antibiotics. But now we are at crossroads. We have come to a situation where our armamentarium, our quiver for all this, the arrows, is empty now with the new development of newer resistant bacterial species like the NDM-1 or the MRSA or the KPC or the VRE. Are we defeated? Is there anything beyond the antibiotics which we can do not to conquer the infections? Strategies for living in a world of emerging infections and antibiotic resistant bacteria is a newer topic. Most important thing is the hygienic measures and then the prevention aspects of bacterial transmission. Antibiotic crisis, antibiotic alternatives, the supercharge, the newer antibiotics, drug resistant bacteria, development of newer drugs, testing them, and of course using them. And again the bacteria start learning against those bacteria, those antibiotics that have resistance. The most important thing is cut down on unnecessary use of antibiotics. Inappropriate use of antibiotics should be minimized, and every pathogen that we want to treat should be adequately, properly treated with appropriate antibiotic for the required duration of time. Don't give a half-hearted attempt or approach while treating bacterial infections. That broods antibacterial resistance by various mechanisms which we have already seen. So with these words, I would like to thank all of you for being with me, and then I would like to conclude the CME on Superbug. The most important point is antibacterial resistance. Bacterial resistance is a commonplace, and bacteria learn to live in spite of whatever antibiotics we use. We need to fight with the bacteria, keeping in mind that the armamentarium is getting empty and we require newer drugs, and appropriately, judiciously use the existing drugs. And of course, safe infection control practices and then hand hygiene, cough etiquette go a long way in preventing the spread of drug resistant strains.